Welcome to another episode of the Compounding Center Connections. Here we talk to our trusted healthcare professionals about different health conditions that patients are experiencing. My name is Megan Kilkeary. I'm one of the pharmacists here at the Compounding Center in Leesburg. And today we have Jim Paoletti as our guest on to speak with us regarding hypothyroidism and lots of interesting aspects of that we're going to touch on today. So really excited to bring this segment to our viewers. I think you're going to find a lot of interesting material in here that you haven't necessarily heard before about hypothyroidism. So Jim is a partner with us here at the Compounding Center. He has over 40 years experience in bioidentical replacement hormone therapy. He is a consultant. He has had a clinical practice where he consults patients on a variety of different hormonal issues. So we're really excited to partner with him and have him speak with us on a lot of different issues. So Jim, give us a quick rundown about your background and who you are, and then we're going to get into some hypothyroidism. I know we were joking earlier, you could talk about this for hours, literally.
And I actually did a 6-hour lecture on hypothyroidism one time. I started out as a pharmacist, got into compounding, went on from there into education as a consultant for compounding pharmacists, and grew from that. Had an opportunity to actually become a faculty member on the Fellowship of Functional Medicine, and there I got to take the classes. So I got to take enough functional medicine classes. One would cost a doctor about $60,000. In exchange to do something I love, teach. And two, I'm an advanced fellow in functional medicine. That's where I lie today. I call myself a functional medicine consultant. Yes, I'll do hormone consults, but if you have other issues that I see in your health history, we're gonna address those too, if we can.
Yeah, absolutely. And Jim has written a book on bioidentical hormone balance. And in fact, the chapter in his book related to hypothyroidism is called A Functional Approach to Hypothyroidism. So Jim, like I said, we're going to take a little bit different approach to talking about hypothyroidism today. So tell us, what do you mean when you say a functional approach to that, being that you are a functional medicine practitioner?
The functional approach is just like in functional medicine, everything in functional medicine. It's dig deep, find the cause of the issues, treat the cause, not just the symptoms.
Mm-hmm. Mm-hmm. So what are some of the symptoms of hypothyroidism in the patients that are coming to you that you're seeing?
There's a ton of them. They run anywhere from headaches to depression to low body temperature, cold extremities, sensitivity to cold. One of the ones that's classic is high cholesterol, maybe elevated triglycerides. Mm-hmm. People find that shocking, but no, cholesterol's metabolized all the sex steroids and aldosterone and cortisol, and that all starts with conversion to pregnenolone, which is regulated by T3, the active thyroid hormone. So if you're low on thyroid function, you don't convert, your cholesterol numbers go up. Mm-hmm. That's what address high cholesterol is, fixing your thyroid. But it also proves you can have that puffiness around your eyes, swelling in your ankles, your hands, called myxedema. You could have dry, brittle hair. That's a common sign. Brittle or breaking nails. Constipation's another big one. You could have problems, decreased sweating, hearing loss, decreased stamina, and the other biggie, weight gain. Absolutely. That's just a list of more common ones.
Sure, absolutely. So those are the symptoms that you see. So what are some of the causes of hypothyroidism in patients? What's the main cause that you see in your patients?
There is no one main cause. There are a number of causes. And this is what I ask myself every time I deal with a patient with symptoms. What are the possible causes? The number one cause of thyroid disorders in the United States overall is an autoimmune reaction. Mm-hmm. Okay. You may not produce enough. So there's another cause. Are you making an optimal amount of thyroid hormone in your gland? Are you converting the T4 that you make in your gland to the active T3? Are you binding the hormone extensively? Because if you bind it extensively, you don't have enough free hormone to work at the receptor. Are you transporting that properly into your cell? Are you having good intracellular transport down to the DNA where it has to work? And is your thyroid receptor responding correctly? So there's multiple levels where there can be a problem that cause symptoms of low thyroid function. And to be honest with you, in most patients, it's more than one.
Yeah, absolutely. As far as testing goes, I'm sure a lot of our patients that are tuning in have had various types of thyroid tests done. So I know there are a plethora of them out there. And I'm sure you could spend an hour just on testing. Can you give us a quick 30,000-foot view of thyroid testing and how you feel about it, and about the numbers and values that sometimes people see that aren't necessarily indicative of what might be going on for them?
Sure. Unfortunately, in my opinion, the way we test thyroid, quote unquote, in practice today is not a very appropriate way to do it. It's not thorough enough. I've practitioners, they check nothing but TSH, thyroid stimulating hormone. That's not a measurement of your thyroid. That's a messenger that tells your thyroid to make more when you need it. So you're not measuring any thyroid hormone. TSH is not that great a test in two senses. Number one, the range goes way too high. The endocrine experts suggested over 10, 12 years ago that the range should be no higher than 2.5 or 3.0, two different groups. Labs are up to 4.5, 6.5, which means a lot of people have problems and the doctor says you're fine, because there's a lot of doctors out there, that's all they check. TSH is a screening tool. By definition, the science behind it, a screening tool is a test that says if I'm out of my normal range, do further testing. That's all it was meant to be used for. Unfortunately, doctors use it today to diagnose if you need thyroid medication, digestion medication. That's all done incorrectly. TSH should not be for that. What I would rather look at is those tests that will answer the following questions. Do you have an autoimmune reaction? Are you producing enough? Are you binding too much? All these things we learn the causes. If you run a certain series of tests, you can answer most of those questions right up front. The first thing would be, are you running thyroid antibodies? If that's the number one cause of thyroid disorders in the United States, it's an autoimmune reaction. And by law, let's say I was only allowed to run one test and you have symptoms, I'm not running TSH. A TSH is a screening tool. What's the best screening tool we have? Your patient's symptoms.
Right.
If your patient's symptoms say you need to dig deeper, okay. So I'm going to run an autoimmune. If I can ever run, it's going to be a thyroid antibody. Just rule out the number one cause. But then if I measure a total T4 or free T4 or free T3, I can look at those in a certain way by comparing where they are within the ranges to determine, are you producing enough? Are you binding too much? Are you converting properly? Then I'm going to look at the factors that affect all the other things I talked about. I'm going to look at cortisol, because high and low cortisol both interfere with thyroid receptor absorption, etc. I'm going to look at vitamin D that affects your thyroid receptor response. I'm going to look at ferritin, critical to intracellular absorption. But I'd have to say I'm going to look at those differently than most doctors. Your normal range is not optimal for many of these things. Okay. The best one is vitamin D. You can come back with a vitamin D level of 32. You're normal, because low starts at 30. And I always point out to people, look, that 30 as a low end came about years and years and years ago when we discovered if you had 30, you weren't going to get rickets. Right. So if you have 32, I say, congratulations. Odds are you aren't going to get rickets. Your thyroid receptor is not going to work at 32. You need to get that up to at least 60. You want ultimate effect on bones and heart protection, etc. You need to get up to 60. So I have optimal ranges for each of these tests. But when we can take those tests, look at optimal ranges, compare the results, and we can start answering questions of which causes are happening in this patient.
So it's interesting you bring that up, because that brings me into, a lot of patients, I'm sure you have seen over the years, have come to you and are exhibiting the symptoms of hypothyroidism. So, but they're saying, but my doctor told me my levels are normal, my results are normal. So what does that mean for you when you have patients coming to you? What red flags are going off for you?
Well, right away, that tells me they've probably only looked at TSH or TSH and T4 for your total.
Right.
And then they're looking at a tip of an iceberg. Where do most problems occur? Below the surface. Those two tests do not reflect, are you converting to T3, the active form? Are you binding extensively, et cetera? And then it comes to patients that are on therapy already. And most patients, they're put on some thyroid therapy, which I don't agree with, because unless you're not producing an optimal amount, there's no reason you need thyroid therapy. There's another problem. But they come to me, and the first thing I ask them is, well, did your physician practitioner, when they were looking over the test results, ask you when you took your last dose of thyroid medication prior to the blood draw? The answer is always no. I'm going like, well, you can't interpret the results then. If you're on thyroid medication, you've had thyroid tests, and what's my first question? When was your last dose prior to the blood draw? You can't interpret otherwise. You need to know, am I looking at a possible peak? Am I looking at the level amount that's produced most of the day? Am I looking at a trough? And I guess that comes from being a pharmacist, the pharmacokinetics of the dosage form, right? We know what's going on. It's going to go up, and T4 is going to be up for a couple hours, at least to 4 hours, and then go down. It could be steady, and it's going to drop off in 20 hours. So as a pharmacist, we know, hey, we want to look in a certain window.
Right.
Doctors don't do that. I have never asked this question of a patient and gotten a yes. I'll ask them, did anybody tell you when you get your thyroid test done that you should be sitting perfectly still for at least 15 or 20 minutes prior to that blood draw? Nobody's ever told them. However, I've had it confirmed by phlebotomists. It's in their textbooks. Phlebotomists are supposed to be trained that if a patient's doing thyroid medication, they can't have any movement. And actually, it's in a textbook for 30 minutes, but no, good luck getting a patient sitting or rest. If I get 15 minutes, I'm happy. But if you've used your muscles in those 15 minutes, just before you get your blood drawn, you're now converting T4 to T3 at a more active rate to restore the energy stores, mitochondrial energy stores in your muscle tissue. So your pre-T3 now thrown off. And I've seen it thrown off pretty significantly. So there's little things like that. It's not just which test you run. Are you doing it properly based on what you're taking and how it should be done? If we can fix those things and we get a good evaluation, it's not that hard to fix thyroid problems. We're making it too hard on ourselves by not asking the right questions, in my opinion.
Right. And not looking at the right potential causes either. Yeah, like you were saying, conversion issues is a big issue in a lot of patients.
Yeah, and each one of those things we mentioned, like if you look at any of those questions, are you producing enough? Very much. The answer is yes. You're doing this. You're not. Let's say you're not converting. Are you converting well? No. What's the next question? Why? See, it's a series of two questions at every step. Are we doing this optimally? If not, why? What do we need to fix?
So how do you fix that?
Well, if it's conversion problems, the two chief culprits are high cortisol and poor nutritional support. So address those two. There's a book called Overcoming Thyroid Disorders written by David Brownstein that lists 32 possible reasons. So I always go over all those medications, et cetera, obesity, too much alcohol. But the two ones I see most common are high cortisol and just lack of a number of nutritional things, vitamins, zinc. So I usually give a nutritional support product. If they're low on, of course, on ferritin and vitamin D, I'll just take, based on where the level is, I'll dose those in order to get up to optimal. If there are other issues like you're not producing enough, my first question will be, okay, do you have enough iodine in your system? If you need 4 molecules of iodine, make 1 molecule of T4. If you don't have enough iodine, what's going to happen? You can't make it. So I always try to fix the problem first. Last resort is, okay, we can't get them to make enough T4, so maybe we got to consider thyroid therapy. That's the only time I consider thyroid therapy. It answers, you are not making an optimal amount, and I can't get you to make enough. And there are other nutritional factors that go into the formation of the T4 molecule. So I look at the nutritional support. At each step in thyroid metabolism, there are numerous nutritional either coenzymes or cofactors. So we look at good nutritional support for fixing thyroid a lot.
Yeah, absolutely. Selenium, zinc, chromium, iodine. I know you've talked about a couple of these already. It's so important, and you taking the functional approach, like you said, you are often able to see patients overcome these hypothyroid symptoms through this functional approach, between lifestyle and nutrition versus just throwing some, thyroid medication on them.
Absolutely.
Yeah. Yeah. Anything else that you see in your patients that is important? I mean, I know we've talked in some of our other podcasts about, thyroid, adrenal, hormones, they're all interconnected. So, and you touched on too, cortisol levels affecting thyroid as well. Important to check all of these things and make sure that all of these different systems are working before, you can just fix a hypothyroidism issue in these patients, right?
Right. And I think the most important one to assess at the same time you're assessing why thyroid issues is the adrenal function. Mm-hmm. One, because high and low cortisol both affect thyroid metabolism and the receptor and all, but more importantly, if you have deficiencies in adrenal function and thyroid function and you just fix the thyroid and you increase your metabolism, if you're deficient in your adrenal function, they may not be able to handle the increase in metabolism. And you can put a patient on these fixes, whether it be nutritional therapy, whatever, and their metabolism kicks up over the next 2 or 3 days. They feel better, and all of a sudden their adrenals can't handle it and they crash. Mm-hmm. So I always tell people, you have to assess the adrenal function at the same time you do the thyroid and address both. You cannot fix either one without, you can fix the adrenals without thyroid, but you can't fix thyroid unless you've addressed whether you need to fix the adrenals at the same time, or you can worsen it. If the person's got high cortisol and you increase their metabolism by fixing the thyroid issue, you just sped up the breakdown of muscle and bone. Mm-hmm. Not something you want to do, which causes more inflammation, more bone loss. So adrenals and thyroid go hand to hand as far as if we need to fix one, we need to look at both.
Yeah, absolutely. What age do you start to see most people exhibiting these, hypothyroidism issues? Is there, for a lot of women, is it as they're starting to enter into that menopause phase? Do you see it earlier? What do you see in your clinical practice?
All ages. Mm-hmm. All ages. It used to be, I'd say, typically when they get into perimenopause, you got to understand a woman going into perimenopause. Okay, this is usually somebody who's taking care of a family, mm-hmm. works a job, and got a husband they got to take care of too. And they've had a lot of stressors. And now they're getting into the symptoms of perimenopause. And she wonders, is she going to lose all her hair? Is she ever going to be skinny again? Mm-hmm. I said, I can't remember where my keys are, much less my kids' first names. Am I getting Alzheimer's? I mean, those have got to be stressful symptoms, right? Mm-hmm. But she has cortisol issues more often than not. Most perimenopausal women do, which interferes with thyroid. So you're going to see thyroid symptoms then. Mm-hmm. But I'm seeing it more and more in younger people now because they're just too stressed. Uh-huh. And so you don't see them as severe when they're younger, but you do see a good number of low thyroid function. Like I said, I've seen a record number of younger patients in the past year. And consistently what I see across them is adrenal issues, neurotransmitter issues, and thyroid issues, usually resulting from the adrenals. The good news mm-hmm. is this: if your thyroid issues are caused by your abnormal cortisol levels, work on the adrenal for a couple of months, and you probably got 50-50 chance your thyroid symptoms are going to clear up too. Right. So that's again, depending upon that individual, sure. My usual approach, if I think the thyroid symptoms are being caused by the cortisol issues, I'll work on those first, and the thyroid symptoms hopefully will go away on their own. Mm-hmm. Mm-hmm.
Great information. Thanks so much, Jim. To let our viewers and our listeners know, Jim does consultations, as I'm sure you've already picked up on us speaking here today. If you're interested in reaching out to Jim or us here at the Compounding Center for some more information, we will give you our contact at the end here. So, please, as always, feel free to reach out to us if there's any questions or if we can help you in any way. Jim has been invaluable for thousands of patients over the years with helping them overcome as you can hear, thyroid issues, adrenal issues, hormone issues, and he takes a fantastic functional approach to all of that. So like I said, we wouldn't know what to do without him here at the Compounding Center. So we're so happy that he partners with us and has just a wealth of knowledge on all of these topics. So again, thanks, Jim, for joining us today and sharing with us just a small piece of your knowledge when it comes to that hypothyroidism here. Again, we will go ahead and put information out there for you too if you're looking to reach out to either one of us. So again, Jim, thank you, and we'll look forward to speaking with you next time.
Thanks, Megan. Looking forward to it too.
All right, take care.
All right.